Hello, I'm Alexandra Harrison for Supporting Child Caregivers, and this is the lecture of the Infant Mental Health mini-course that we have developed. I want to begin with 3 ideas that form the foundation of the course. Then I will explain more about why infant mental health is so important. And finally, I'm going to give you the content of the lecture, organized into categories that we consider to be the parents' tasks to protect, nurture, and enjoy their baby. Here are the 3 key ideas. Number 1, stressful life experience can harm brain development during pregnancy and in the first months of life. Number 2, the parent-infant relationship can moderate, at least in part, protect the baby against the effects of this stress. And number 3, nurses and other health workers can support the infant-parent relationship and in that way promote healthy development of the child and of the adult that the child will become. Now let's return to a discussion of infant mental health and why it's so important. Infant mental health is the study and practice of supporting healthy development in infancy and in the first years of life. Infant mental health begins with the parent-infant relationship. As I said, the parent's ability to protect, nurture, and enjoy their infant can buffer the effects of problems in the infant's life. Over and over again in this course, we will emphasize the importance of supporting this relationship. Nurses can support the infant-parent relationship by helping the parents bond to their baby. Infant mental health is actually the cornerstone of a healthy and successful life, even in adulthood. That's because the development of the infant's nervous system during pregnancy and in the first years of life forms the foundation for a set of core competencies necessary for future success. These core competencies include the ability to focus attention, make transitions flexibly, inhibit impulses, and plan actions towards future goals. These core competencies also include the ability to make and sustain trusting, affectionate, and reciprocal relationships. All this is beginning at the beginning of life. Well, what predicts a healthy life? Well, T. Barry Brazelton has said, "For years it has been my belief that the quality of the infant-parent relationship and the child-parent relationship is the best predictor of outcome for any child." There is another important predictor of outcome, though, and that is the amount of stress in the individual's early life. The famous ACE study demonstrated that the number of adverse early childhood experiences predicted the health outcome of the adult, and that includes medical illnesses. So we believe that interventions supporting the infant-parent relationship are the most effective way and the most efficient way to promote health and success in adults. Now this mini-course is going to show you how a nurse or other health worker or any caregiver of infants and their families has the potential to change the course of a child's life in a short number of brief interventions. The secret of the power of these brief interventions is 1, the timing in pregnancy or in the first months of life, and 2, the focus, the infant-parent relationship. These interventions attempt to help the parent make a connection to or bond with their infant. It's possible that the most cost-effective way to make a society stronger is to support parents at the beginning of the life of their child. As I mentioned, we at Supporting Child Caregivers believe that the task of the parents are to protect, nurture, and enjoy their baby. And so supporting the parent-child relationship means helping the parents protect, nurture, and enjoy their baby. In this course, we're going to talk about how parents can do this, how they can protect, nurture, and enjoy their baby. And first, we're going to discuss how parents can protect the baby, We're going to describe brain development and the effects of stress on the developing nervous system. We will identify the sources of these stresses, and we'll show you how the parents' and infants' brain change to prepare them to bond with each other in a way that can protect the baby. Then, we'll discuss how parents can nurture their baby. We'll demonstrate an effective tool to introduce the infant to her parents by showing the parents their own baby's strengths and sensitivities. This tool is called the Newborn Behavioral Observation, or we refer to it as the NBO. And we'll illustrate the ways a caregiver can introduce support for the parent-infant relationship into brief contact with parents and their infants using some cues from the NBO. Finally, we'll introduce 2 scientific theories that attempt to explain how parents nurture in their babies the ability to regulate themselves. That is, the parents can help the babies learn to regulate themselves so that they can feel safe and have a sense of security and well-being. These 2 theories are attachment theory and the mutual regulation model. Finally, we'll talk about the problems that interfere with parents' enjoyment of their baby. These include problems that originate in the parents, such as postpartum depression, but also problems that originate in the child, such as prematurity and developmental problems like autism. We will mention, but very briefly, some interventions and a way that caregivers of families of infants can care for themselves in their very stressful work. That is called reflective practice. And finally, we are going to return to a summary of some of those guidelines I referred to for supporting the parent-child relationship, so that nurses can use them and other caregivers can use them in their work with these families. Now we are beginning the lecture, and I want to give you 4 important ideas that organize the material of the course. The first is that the foundation of health and well-being begins in infancy. The second is that health problems result from a combination of genes and the molecules that infect the expression of genes and the environment. Infants may be protected from a poor environment and even somewhat from genetic problems by good caregiving. And finally, and very important, nurses and other health workers can promote good caregiving by supporting the parent-infant relationship that can buffer some of the problems of the poor environment. You can see why we think this is so important. Protecting the baby is our first subject. Protecting the baby begins with a safe and healthy pregnancy of the mother. That's because the baby's development depends on the health and well-being of her pregnant mother. Protecting the mother includes making sure that she has a safe environment and clean water and good prenatal care, good nutrition, and also a supportive social system. The supportive social system is very important. It includes the family and other resources in the community that can support the infant's parents. The parents of the baby protect the baby from harm and respond to the baby's physical and emotional needs. But their parents and other extended family, siblings, aunts and uncles, they can all protect the parents from the threat of harm, and they can share in the care of the baby. Also, community supports are important. They can protect the parents against the threat of violence and the threat of economic insecurity. Now, as we've said, one of the most important ideas in this course is that stress has a negative impact on the growth of the developing child, especially at the beginning. Chronic poverty, domestic violence, physical or emotional abuse, or substance abuse, homelessness, all this can influence the developing nervous system of the infant. It does this by amplifying or making bigger the part of the nervous system that responds to immediate stress, rather than building up the essential core competencies that can help manage stress in a more stable and long-lasting way. Let's review some of these core competencies because I referred to them before. They are often called executive function, and they include being able to focus attention, manage transitions flexibly, inhibit impulses, and plan actions towards future goals. In order to build these executive function core capacities, which are very important skills to adapt to a successful adult life, as you can see, the infant's developing nervous system must be protected from severe stress. The pregnancy and the newborn period is a very powerful time to intervene in this regard. There's growing evidence that the early caregiving relationships have a very important influence on the child's social, emotional, and cognitive development, and even the long-term health outcome, as I mentioned before. Although these competencies continue to grow throughout life, the period of greatest growth occurs in utero and in the first months of life. The pregnancy, birth, and the newborn period involves a series of life-changing transitions for the infant, also for the parents. And the times of transition are very well suited for intervention because the nervous system is already in the process of rapid change. Let's take a look at brain development. One way of describing brain development is to say that nerve cells, for example neurons, that fire together, wire together. That means that practicing an act builds neural circuits and the capacity to do that act better and more easily. The brain develops in response to what we do, that's practice, and also what we experience. In addition, though, there are sensitive periods in development when adverse conditions such as toxic chemicals, viruses, and other pathogens, or stress in the mother have a particularly damaging effect on the developing nervous system. For example, adverse experiences during pregnancy and in the first year of life can affect the individual's stress in infancy, but also later in life. However, remember the importance of the infant-parent relationship in buffering these effects, the effects of these stressors. Protecting the baby means supporting healthy brain development. We can illustrate brain development with Siegel's hand model of the brain. This is an ingenious and simple way of demonstrating the basic architecture of the brain. We can use it to orient ourselves as we talk about brain development. My wrist illustrates the brain stem, the lower and first developing part of the brain. My thumb illustrates the midbrain, the limbic system, and my fingers illustrate the cerebral cortex, the thinking part of the brain and the last to develop. We're particularly interested in the effects of severe stress on brain development, what functions are affected, and what are the most sensitive times in development when stress is most damaging. Adverse effects in the environment can affect the brain at different stages of development and affect different functions. Simple regulatory functions, respiration, heart rate, blood pressure, temperature control, are mediated by the lower parts of the brain, the brain stem and diencephalon. More complex functions, language and abstract thinking, are mediated by the cerebral cortex. A potential threat triggers activity in the lower parts of the brain, and that activity moves up to the more complex areas of the brain, so that lower parts of the brain respond quickly before the signals get to the higher levels, such as jumping back when you see a snake. Remember at the beginning of the lecture when I talked about how severe stress can create a heightened stress response in the lower part of the brain at the expense of the more reasoned response of the cortex? The brain develops in a sequential fashion. The lower part of the brain that controls the automatic response to stress develops first, and the higher, more complex parts of the brain, the thinking brain, develops last. The prefrontal cortex doesn't come online until about 1 year of age. And also the brain develops as I've mentioned before, most rapidly early in life. By age 4 years, the child's brain is 90% the size of the adult brain. Adverse effects that occur during the time particular parts of the fetal brain are developing may affect functions that are mediated by those parts of the brain. That's why it's so important to understand the brain and brain development when we study stress regulation. For example, infants who suffered high stress in utero or in the first few months of life may be very intelligent, but they can only manage stress by primitive means, and they tend to be highly anxious people. Interestingly, parents' brains are changing in preparation to meet their baby. In order to support the infant-parent relationship, we need to know something about how nature works to prepare parents' brains to meet their new baby. It turns out that the infant-parent relationship is designed to protect the baby because, for example, adults are innately attracted to the infant's appearance with disproportionately big head and large eyes. Also, the mother's brain is being prepared during pregnancy to care for her new baby. There are changes in key regions of her brain involved in reward and motivation and stress and emotion regulation and the production of certain specific hormones and neurotransmitters. Pregnancy actually changes the architecture of women's brains. Also, peptides such as oxytocin and vasopressin, both of them important in the brain's work in social recognition, which is the ability to recognize social cues, and social memory, are released during labor and childbirth and nursing, and they contribute to the mother-infant bonding at those times. We know something about kangarooing, it's called. That has to do with skin-to-skin contact of mother and infant or father and infant with premature babies. We have found through studies that oxytocin is increased in those babies and reduces stress and anxiety in these premature babies when they have skin-to-skin contact with their parents. Let's take a look at the areas of the brain that I referred to before, such as those involved in reward and motivation and stress and emotion regulation and the production of oxytocin, because they're so interesting. Imaging studies show that mothers' use of the brain regulated by dopamine, which is involved in reward and motivation, they use those regions when they see their own infant smiling face, but not another infant smiling face. So their brains are prepared to prefer to pay particular attention to their own babies. Also, brain regions associated with motivation and reward, including the prefrontal cortex right here and the amygdala right here, are engaged when parents interact with their own infants. Stress and emotion regulation is important too, because mothers tend to respond with greater positive emotion when viewing their own babies and with greater stress when their own babies are threatened. Both parents, fathers and mothers, worries and mood are stimulated by their own baby cry. Then there is the famous hormone oxytocin. Sometimes it's referred to as the love hormone. Oxytocin levels in the blood increase when mothers view the faces of their own infants compared with the faces of unknown infants. But oxytocin is also important in romantic love, and as a matter of fact, it has been shown to facilitate the resolution of conflict when couples are fighting. Now, it's not just the parent's brain that's being prepared to meet the baby's brain is being prepared to meet the parents in utero, being prepared to meet and engage the parents. So babies start learning speech in the womb and prefer the mother's voice. The infant can also learn simple rhymes and narratives in the womb, and melodies the fetus has heard in utero can be recognized by the infant after birth. Also, neural circuits involved in the emotional and social interactions are already present in immature forms in the newborn, so that cortico-bulbar pathways in the brain are sufficiently developed at birth to allow the newborns to signal the caregivers with vocalizations and grimaces and to gaze and smile. And neuroregulation of muscles prepare the newborn for social cueing of the caregivers with gestures and facial expressions. At birth, the infant is attracted to the odor of his mother, including the scent of her amniotic fluid, so that infants are soothed from crying by their mother's odor. And then they use the mother's odor to organize their behavior for nursing. Another really interesting fact is that although older children and adults are able to discriminate one individual from another best by looking at age-matched individuals, so that human children can distinguish one child from another by looking at children of their own age, and adults by looking at adults, that's not true for infants. Human infants, remember, are prepared to meet their parents, and so they're much better telling faces apart when they are adult faces. I thought that was really interesting. Babies' brains are preparing to enter the social world. Babies prefer human faces to other visual images, will gaze longer at an image with a configuration of a human face than at a blank face or one with scrambled features. Infants also gaze longer at a face with eyes open than with closed or averted eyes. Studies show that infants can imitate an adult sticking out his tongue or opening his mouth wide. This capacity is called cross-modal imitation and can be very important in supporting bonding. Also, infants' vocalization constitute what Trevarthen calls proto-communication. These vocalizations call for a response from the parents and begin to create a parent-infant dialogue, which is not only important in infant-parent bonding, but which lays the foundation for the development of speech. Trevarthen has a video of a mother singing to her blind infant, in which the infant uses her tiny hands to conduct the music of her mother's song. In the course, we show a video of the newborn recognizing his mother's voice. In the video, you see the father cleaning and diapering the baby in the delivery room, and the infant is crying. The mother speaks the baby's name, Andrew. She says, "Andrew, Andrew," and the baby turns in the direction of the mother's voice and starts to calm. In a comforting voice, the mother says, "Don't cry, it's okay. I know, it's cold, I know." This is key because it shows that the mother is making meaning of the baby's cry. She's imagining the baby's mind. This is an important part of parenting and allows the parent to respond empathically to the child's communications. As the mother continues, "That's okay, baby, that's okay, baby," in a gentle voice, the baby remains quiet and then puts his hand to his mouth. He is already beginning to learn to comfort himself as he is surrounded by his mother's comforting voice. In another video, we see the comedian Michael Jr. talking about how what he enjoys most is being a dad. He describes his experience in the delivery room when his youngest daughter was born. She's crying, but when she hears his voice saying, "It's okay, baby, I'm right here," she calms. A few minutes later, when the nurse starts cleaning her, she starts crying again. Michael Jr. speaks up again, and he tells her, "I'm right here, I'm right here." She quiets again. Then he continues speaking and says, "I love you," and at these last words, she opens her eyes. you can see how powerful that kind of bonding infant-parent relationship can be. Now we've reached the end of protecting the baby, and next we will discuss nurturing the baby. Nurturing the baby means providing the baby with shelter, food, and a loving relationship. Nurturing begins in the womb with the physical and emotional well-being of the mother as the foundation. At delivery, the baby sees his parents for the first time and begins a different kind of relationship, a relationship in which the parents help the baby get ready for living in the world. As we've seen, both parent and baby are prepared to meet each other, and when the circumstances are healthy, to fall in love. Labor and delivery are very critical times in a woman's life and also in a man's life. During labor, powerful forces take over the mother's body, and the mother's condition at delivery has an important effect on early bonding. Kindness and sensitivity at this time in a mother's life leaves a lasting good memory, but insensitivity at this time can be highly stressful and even traumatic. This is another example of the importance of helpful intervention at a particular early time in a mother and infant's life. In the first few months of life, the newborn is challenged to adapt to the world outside her mother's body. She has to learn how to organize autonomic or physiological behavior, such as stabilizing breathing, reducing startles and tremors, and maintaining temperature control. She has to regulate motor behavior, control random movements and develop good muscle tone and control, and reduce excessive motor activity. And she has to organize her state into strong, predictable sleep-wake cycles, and then protect that sleep. And finally, she has to learn how to regulate, how to calm herself when she gets upset. The last important challenge is to learn how to respond in social interactions. We call this responsiveness. That means she has to maintain prolonged alert periods. She has to be able to attend to visual and auditory stimuli, and then to seek out and engage social interaction with her parents. Kevin Nugent has developed the NBO, the Newborn Behavioral Observation, which is an interactive relationship building tool designed to strengthen the relationship between parent and infant in the newborn period. This is based on the idea that the quality of early experiences drives brain development and functional outcomes, similar to the thesis of our Protect, Nurture, and Enjoy mini-course. Remember how Brazelton said that the quality of the infant-parent relationship was the best predictor of outcome for the child? The NBO shows the parents their infant's strengths and sensitivities in a way that engages the parents' interest in their baby and brings joy to the experience. And the NBO may also suggest to the parents ways to support their particular infant's developmental needs. We demonstrate the NBO in the course, but do not train students in the NBO. Hopefully we will be able to do that in the future. And I do want to emphasize that the NBO is not an assessment tool. Nugent organizes 8 categories for exploration of the infant's developmental capacities into categories labeled by the mnemonic AMOR, which means love in Spanish. A stands for autonomic, M for motor, O for organization, and R for responsiveness. So let me repeat what they stand for. A, autonomic and physiological stability, has to do with the stabilization of breathing and temperature regulation and reducing tremors and startles. M for motor regulation has to do with developing good motor control and feeding skills and the ability to maintain a controlled activity level. Organization has to do with the ability to cope with stress and to regulate state and develop predictable sleep-wake patterns. And responsiveness has to do with the development of the growing awareness of the environment and the capacity to process auditory and visual stimuli, and very important, to engage in social interaction. Now, beginning the ENBO means observing the baby. The nurse, for example, might say to the parent, "Let's see what your baby can tell us about herself." You are trying to make it possible for the parents to recognize the baby's communications so the parent can imagine his baby's mind and meet his needs. It is a baby-led session in the ENBO. The baby's behavior guides the order of tasks. You begin by observing the baby's initial state. If the baby is asleep, you start with visual and auditory stimuli to test the abilities of the baby to protect his sleep. This may be all you can do in one session if the baby remains asleep. But if the baby is not asleep, you can elicit or guide the parent to elicit a hand grasp, sucking and rooting and crawling reflexes, and you can observe the quality of the motor tone and activity level of the baby. You can look at the infant's ability to respond to the face and voice and to inanimate objects such as a red ball. All the time you're noting the baby's state regulation and what consoles the baby, what comforts the baby. In one video of an ENBO, the nurse is holding the baby near the mother. The baby lifts his head in the direction of the mother's voice as she's speaking and opens his mouth. The nurse asked the mother if she noticed what he was doing. The mother responded that she saw him open his mouth. She says, "He does that to tell me that he's hungry." And the nurse says, that is good that the mother can understand just what the baby is telling her. That allows her to give him what he needs. Just like the mother in the delivery room who tells her baby, "Don't cry, I know it's cold, I know." Again, we see that the parent's ability to imagine the mind of her child allows her to effectively care for him. The nurse affirms this capacity in the mother, which supports the mother's sense of herself as a good mother. In another video, the mother is holding the baby and the father is standing by her side. The father leans over, takes his finger, and presses it into the palm of his new little daughter. She grasps it tightly in her tiny fingers, and the father beams with delight. The nurse expresses appreciation. She says, "You demonstrated an important reflex called the Palmer reflex. You knew it before I could show it to you." Again, the nurse communicates to the father her own recognition of the father's knowing his baby. She is in effect saying to the father, "You are the father of this baby. You know her better than I do." This kind of communication supports the father's bonding to his baby. We can take from the ENBO some guidelines for supporting the parent-infant relationship. The nurse can use some of these ideas from the ENBO in her meetings with parents and infants. First, introduce yourself to the parents. Smile, make eye contact. Show caring and concern, for example, by asking about the mother's experience of her pregnancy and delivery and how she's feeling now. Then, continue to make a connection with the parents through observing the baby and talking about your observations with the parents. For example, you might comment on the baby's sleep or alert state. You might say, "Oh my goodness, he's such a good sleeper." Or you could say, "Look at how wonderful and alert your baby is. She must be very intelligent." You might point out the baby's awareness of the parent's presence. For example, if the baby turns to the parent's voice or gives a hunger cue. You can facilitate the baby's turning to the parent's voice by putting the baby's head in the midline, placing the baby's head in the midline, and then asking the parent to speak to that side of the baby and the baby will often turn to the parent's voice, which again is a very powerful facilitating experience for the parents bonding to the infant. Always you want to validate the parent's efforts to respond to the baby. If the baby cries, you don't rush to pick the baby up, even if you imagine that you could comfort the baby. You allow the parent to do it. You can help the parent do it by pointing out that the parent seems to wish to comfort the child. What does the parent know is comforting to the child? Have a conversation with the parent about that, but you always try to let the parent be the parent in the interaction. You also might inquire about or comment on the support system that the family can rely on when they return to their community. What you are doing is first attending to the parent and then focusing on the baby and making little links to the parent in your efforts to support the bonding between parent and infant. Another way of supporting the bond to the baby is to ask the parent to sing to her baby or to sing to his baby. Music welcomes the baby into the culture of the family. Music is the carrier of emotion, and songs of the mother to her baby or the father to his baby link generations, in that way bringing the mother's parents into the room or the father's parents into the room and eliciting the mother's or father's own experiences of being cared for. In the course, we show videos of parents singing to their newborns. In one video, the father is singing a song of the stars looking for the moon. The baby, whose eyes have been tightly shut, slowly begins to open her eyes. This experience strongly supported the father's bonding to his new baby daughter. So we have talked about how to nurture the baby, and we must help the baby learn how to calm herself when stressed. Try for a moment to consider the stress in your own life and how you try to regulate yourself when you're stressed. It will give you insight into how to help new parents deal with the stress that they feel. We've seen that the first order of business is to protect the baby and his parents. Only after the parents feel safe can they nurture their baby. Two important theories that attempt to explain infant mental health, explain how the baby uses her parents to make her feel safe so that she can explore the world and grow, are attachment theory and mutual regulation theory. First, let's talk about attachment theory. The three most important names in attachment theory are John Bowlby, Mary Ainsworth, and Mary Main. John Bowlby invented attachment theory, and he described the search for a secure base in the mother as the primary motivation for the infant's behavior. Infants seek closeness to their primary caregiver, that means the mother, for safety and security, Bowlby said. Mary Ainsworth was his student, and she designed the strain situation paradigm in which she identified babies who had secure or insecure attachment categories. And Mary Main was a student of Mary Ainsworth and identified a new attachment category called the disorganized attachment. She also is famous for inventing the AAI, which is the Adult Attachment Inventory. I will tell you a little bit about each of these things. The strain situation paradigm, developed by Mary Ainsworth, is measured at 1 year old. It involves a series of procedures in which a mother leaves her infant with or without a stranger and then reunites with her infant. The key observation is the infant behavior at the reunion with the mother. The categories of behavior at reunion are classified as secure or insecure. And secure versus insecure attachment is later related to or even predictive of, according to this theory, the child's later behavior. Now, types of insecure include avoidant, resistance, ambivalent. They're not considered pathological, but they present an additional risk for problems in the child's later life. The disorganized type of attachment, which you recall was contributed by Mary Main, is the only type predictive of mental illness in the child later on. Mary Main, remember, also developed the Adult Attachment Inventory, which is an interview with the mother about her experience with her own mother and also her father. Attachment studies suggest that the attachment status of this mother's infant at 1 year old can be predicted by the results of her AAI interview when she was still pregnant with that baby. It's quite impressive. Attachment theory, therefore, seems to offer a way of measuring the effect of environmental influence. In this case, it would be maybe maternal sensitivity on the psychological development of the child. Now, there are criticisms of attachment theory, which include the lack of consideration of alternative hypotheses, that is, other reasons for the behaviors that are measured. And another criticism is that there are essentially no studies of sequential children of the same mother. So one might assume that all children of the same mother would have the same attachment and so the same behavioral characteristics. And yet we know, of course, from our experience in life that that is not true. However, attachment still remains a very important theory, an important way of understanding early development. Now, here is the other important way of understanding infant mental health. It is Tronick's mutual regulation model. Until the 1980s, infant researchers thought that a good infant-mother match meant mother and infant spent most of their time together in harmony, but that harmony was largely the responsibility of the mother's activity. In other words, the mother carried the lion's share of this harmonious match with her baby. But in the 1980s, Tronick showed that in well-functioning mother-infant pairs, the infant initiates 50% of the time. In other words, half the time the baby is the one who is doing the work. The work is not all done by the mother. And even more interesting, perhaps, is that the well-functioning infant-mother pairs spent between 20 and 40% of their time together in matched states and 60 to 80% of their time in unmatched states. That is not what people would have expected given the old perspective on harmony. This means that most of the time the infant and mother spend together is not in a matched, harmonious state, but instead is in a trying to get to a matched state. And that actually makes much better sense, because regulation, or getting to calm, good places, is what the infant is trying to learn. The infant is trying to get him or herself to a calm place, to a place that matches with himself. And so this makes sense. This new theory makes a lot of sense from that point of view. Now, nurturing the baby means helping the baby learn self-regulation. As I just mentioned, the capacity to calm or comfort himself. Tronick's face-to-face, still-face scientific paradigm is a way of demonstrating the development of self-regulation from the mutual regulatory activity between the mother and the infant. The still-face paradigm demonstrates the sensitivity of the infant to the mother's communications. It demonstrates the need of the infant for the mother's contingent responses to maintain his regulation. And it demonstrates the need of the infant for engagement with the mother to be content and explore the world and make sense of his own feelings and intentions. In the video of the still face, the mother is playing with her 9-month-old baby girl, and she grasps the baby's hands and moves them in and out, and the baby smiles. And then the mother speaks to her in an animated voice with a big smile, and the baby smiles. And the mother takes the baby's foot and starts to count the baby's toes, and the baby smiles. And then the baby points, and the mother looks to where the baby is pointing in the direction of her point. Then the signal comes for the mother to make a still face. That means she becomes unresponsive to her baby's cues. The mother turns to the baby with a still face. And the baby immediately notices something is different. She looks quizzically at the mother, and then she arches her back and looks up and looks down again to make sure that she didn't make a mistake the first time that her mother had changed in such a drastic way. The baby vocalizes and smiles at the mother in an attempt to engage her, but the mother maintains her still face. The baby points the way she did before and vocalizes while looking for the mother's response. The mother does not respond. The baby reaches out her arms in a gesture to be picked up. The mother doesn't respond. The baby gives a high-pitched screech, but the mother remains still. The baby tries to comfort herself by clasping her hands together and then bringing them to her mouth. And finally, the baby turns her head and her whole body away from the mother. She cries. She can't tolerate anymore the image of her mother's unresponsive face. At the second signal, the mother discontinues the still face and calls to the baby with a smile. But it takes the baby about a minute to make sure that the mother is really back. And then she smiles. This still face is a very powerful demonstration of the mutual regulation that's necessary to help the baby learn to regulate herself. It's the way the baby manages stress to go through this mutual regulation with the caregiver, the mother usually. Self-regulation is the way we comfort ourselves or calm ourselves down when we're stressed or upset. And the foundation of self-regulation is what I just showed you in the still face, the process of mutual regulation in the infant-parent relationship. In mutual regulation, a responsive parent will comfort the baby when the baby is distressed, but leave the baby the space to self-comfort or to explore something when he shows that's something he wants to do. It is in those self-comforting moments when the baby knows that the caregiver is there if necessary, but letting him do it himself, that the baby learns to self-regulate. The process is reciprocal and mutual. Both baby and parent do a dance of up and down with excitement and calm as they play together. They can sense what the other is feeling and what the other does or does not want to do, and they respect that. Now we have reached the end of the section on nurturing the baby, and next we are going to talk about enjoying the baby. In this section, we are going to talk about problems that can arise to prevent parents from enjoying their baby. Some of these problems originate in the parents, such as postpartum depression or chronic stress, and others originate in the infant, such as prematurity or developmental disorders like autism. Wherever they originate, soon the problems belong to both parent and child. They belong to the infant-parent relationship. We know that stress interferes with enjoyment in the parent-infant relationship. As we suggested, stress can originate either in the mother or father or in the child. When it originates in the mother, it is usually because the mother is unresponsive in her caregiving. When it originates in the infant, it is because the infant has regulatory problems, prematurity, for example, or developmental disorders. As we've said, both result in stressed mother and infant pairs. Let's look more closely at stress in the infant-parent relationship. The hypothalamic pituitary adrenal, HPA axis, regulates the production of cortisol, which is sometimes called the stress hormone. When humans are threatened, the stress response begins with two stages. The sympathetic response, that's fight or flight, is mediated by catecholamines, epinephrine and norepinephrine, and is activated within a few seconds. That's when you say, "Yikes, a snake." But if the stress is great enough, the HPA response begins, leading to the release of cortisol. Early, repeated, or chronic activation of the HPA axis may cause the development of an anxiety disorder. Adults with early stressful experiences have increased risk for post-traumatic stress syndrome, PTSD. Problems in the infant-parent relationship may be caused by parents with anxiety disorders or PTSD. Now let's talk about maternal unresponsiveness. The major cause of stress in infants is lack of maternal responsiveness, which can be caused by a number of things. It can be caused by maternal depression and anxiety, that's the most common, or PTSD, or grief and loss, for example, if the mother loses a parent when she's pregnant, or family and other environmental problems such as domestic violence or substance abuse or homelessness, for example. Postpartum depression is actually highly prevalent, although it is often unrecognized. Depression involves a pervasive low mood and a loss of interest, feelings of guilt, and the wish to die sometimes. It includes neurobiological features such as sleep and appetite disturbance, the loss of concentration, retardation or agitation, or excessive fatigue. The proportion of women in childbearing years that have depression at a specific point in time is more than 8%, but the prevalence of women with depression 3 months postpartum ranges from 13% in high-income countries to more than 20% in low-income countries. The time period of the illness is important too. Most women with postpartum depression recover within months, but a significant proportion, up to 30%, continue to be depressed at 1 year. The impact of postpartum depression on the child is powerful. It occurs at a time when the infant's maximal dependency is on his mother, and at a time when the infant is most sensitive to his mother's cues and will be strongly influenced by them. Remember the still face. What happens when the mother cannot engage in this enjoyable mutual communication? Well, mothers with postpartum depression tend to show a general insensitivity to their infant's cues with two main patterns of response. The first is to be remote and disengaged, and the second hostile and intrusive. Infants of depressed mothers are likely to avoid contact with their mothers or to become distressed. Postpartum depression is associated with high risk for poor outcome, but mainly that is in the context of high environmental risk, such as poverty and social disadvantage. It is important to recognize that postpartum depression affects cognitive as well as social and emotional development. Other major mental disorders associated with pregnancy in the postpartum period include post-traumatic stress syndrome and postpartum psychosis. In post-traumatic stress syndrome, traumatic experiences in the mother's life are triggered by the experience of pregnancy, delivery, or caring for an infant. For example, a mother may perceive her infant's crying as demanding or manipulative instead of just perceiving her infant in distress. Or the mother may specifically misperceive her child's separation anxiety and sense of helplessness remember the still face, as anger or coerciveness or a threat. This may cause the mother to tune out the child or even leave the room, and may result in neglect or abandonment or even abuse. Postpartum psychosis is a psychotic depression in the postpartum period. It involves a loss of reality testing, delusions, paranoia, and sometimes hallucinations. It is very dangerous because the delusions are typically paranoid, such as the devil is in the baby, and it can be associated with suicidal or homicidal thoughts, and sometimes even infanticide. Now let's move to problems with infant responsiveness. We're going to focus on how stress originating in the baby can interfere with enjoyment in the parent-infant relationship, and talk about some common problems with infant responsiveness, including the very common ones of the fussy baby syndrome or difficult temperament, also prematurity, birth injury and defect, and less common, autism or other developmental disorders. Typical problems with infant responsiveness have to do with regulation. Regulatory problems in infancy include the fussy baby primarily, which usually means a baby who has trouble feeding or sleeping. Responsive caregiving can often positively influence infant fussiness, but it is not a miracle cure. Normal baby crying is communication of need, such as hunger or distress, and the time an infant typically spends crying progressively increases until it peaks at age 6 to 8 weeks and then gradually decreases until 4 months. It happens at the witching hours, which is babies crying unconsolably in the early evening hours, is a cross-cultural phenomenon. It occurs in all cultures. Excessive crying typically is said to be 3 hours per day for more than 3 days in a week, and as many as 20% of parents report this. Colic is somewhat different. It's excessive crying in a baby who is otherwise healthy and well fed. It may indicate a medical problem. The colicky baby is inconsolable despite adequate parenting and has a high-pitched cry that begins and ends without warning, and often the baby clenches her fists or grimaces, sometimes has an extended abdomen, but only 5 to 10% of excessive crying is ever linked to a treatable medical condition. A common cause, which is cow milk allergy and gastroesophageal reflux, can be treated with a special hypoallergenic formula or reduction of milk products in the diet of a nursing mother. But also important is the reduction of behavioral stimulation, that is, helping the baby be calm and not interacting in an active way with the baby. Temperament is another cause of stress in the infant-parent relationship that starts in the baby. Remember that development results from a gene-environment interaction. Temperament is largely, although not exclusively, genetic, and attachment is primarily, although not exclusively, environmental, having to do with parenting. Temperament is defined as a stable pattern of emotional reactivity, and temperament was first described and studied very carefully and intensively by Jerome Kagan, who identified slow-to-warm-up babies, now typically called high-reactive babies. He said that these babies comprise 10% of the normal population. High reactivity, highly sensitive children are not abnormal, but they do have sometimes more difficult time in life because of their sensitivity. In India, we call highly sensitive children rose flowers compared to easy, relaxed children referred to as grass flowers. Steve Sumi has studied rhesus monkeys who are bred to be high reactive. And also there are mothers who are rhesus monkey mothers who are super moms. When he put the high reactive babies together with the super moms and let the super moms raise them, that these high reactive, difficult temperament babies turned out to be leaders. So that suggests that, at least in rhesus monkeys, parenting has a lot to do with the success of high reactive temperament children. Another interference with enjoyment in parent-infant relationships is developmental disorders such as autism. Autism is highly heritable. It is not caused by the mother. Children with autism have poorly developed capacities of social engagement and communication, and they also have restricting and repetitive behaviors. Other capacities that are poorly developed in autism include the developmental accomplishment of joint shared attention. Remember the baby pointing and her mother looking? That will not be found so much in children with autism. Also, there is the important developmental capacity of pretend play, which is missing or undeveloped in autistic children. Let's look at these features of autism more closely. Problems with social engagement means a difficulty making a connection with other people. Children with autism will often have an averted gaze, will not give you a direct gaze, and will isolate themselves. The difficulty with communication often includes delayed or failure of language development or peculiarities in the tone or rate of speech. Communication is often limited to requests or demands, but not sharing of thoughts and feelings. So you can imagine how that might impact the parent-infant relationship from the point of view of enjoyment. Also, these children tend to have restricting repetitive behaviors, such as an obsessional interest in trains or in dinosaurs, and they also tend to collect objects and to repeat the scripts of videos. In autism, there is an undeveloped joint shared attention, which is a crucial developmental accomplishment. It includes pointing, as I mentioned before, which is a form of calling someone to share attention to you, with you, and also it happens to be the foundation for future learning. Pretend play that I mentioned is also important in autism because it is undeveloped. Children with autism often have an absent or minimal capacity to imagine and enjoy pretend play, especially pretend play with dolls or pretend people. Associated with pretend play is theory of mind, which is the capacity to imagine another person's thoughts or feelings and to empathize. Children with autism often do not find humor in jokes, and it's sometimes difficult for them to lie. In the video of autism, the little boy makes no eye contact with the health worker. He murmurs quietly to himself and wanders away from her. He tries to comfort himself with self-regulatory behaviors, for example, rubbing his tummy or chewing on his shirt. Sometimes he tries to stimulate himself by flapping his hands or jumping up and down. He seems interested in what the other children are doing, but he doesn't know how to join them. Sometimes he sees a toy that another child is playing with, and he grabs it for himself without seeming to recognize that the other child is using it. It's as if, in that moment, the other child is not there. This child can also have impulsive outbursts, grabbing at a friend's face or pinching them. Autism is highly hereditary, but it has as many as 50 candidate genes. In other words, many genes that are found in individuals with autism. Interestingly, autistic-like features in children who have been severely neglected, for example, those that are found in Romanian orphanages, complicate the picture. Autism has been associated with many factors, including parental age, especially the father, but it is not caused by vaccination. It's a spectrum, and SIBs of children with autism often have some candidate genes, but none or only some of their autistic behaviors. This suggests that there must be some contribution from the environment, but not necessarily the infant-parent relationship after birth, perhaps the environment in utero, for example. Now let's consider briefly some interventions that can improve or enhance the infant-parent relationship. First of all, it's important to remember that in order to support this relationship, the intervention must be culturally consistent. Some interventions that have been found to be successful include book sharing by Lynn Murray and Peter Cooper, which teaches parents how to read to their infants in a way that nurtures joint shared attention and cognitive and social emotional growth. Another is fathers as intervention. That's an important method. It engages fathers in the care of their newborns. That can be a powerful asset in the infant's mental health. Enhancing parental care sensitivity through education and direct guidance can be helpful. Home visiting, which involves sending health workers or nurses to the home of newborns and their families, is an excellent intervention to support parents by offering comfort and guidance and protection from isolation. And in extreme cases where parents are unable to protect, support, and enjoy their children, even with a great deal of support, there is institutionalization or foster care. Now, here are some techniques for specific problems. Techniques for autistic children include behavioral or child-led techniques, which are somewhat different and are based on different theoretical ideas, may lead to similar changes depending on the quality of the clinician-child relationship. Trauma therapies identify triggers and create new non-traumatic meanings by introducing a specific stress in doses, in small doses. Interventions for maternal mental illness may try to maintain the infant-parent relationship by, for example, hospitalizing the mother and the baby in the same psychiatric hospital ward and protecting and caring for the infant while they try to maintain the connection between mother and infant. And finally, there's videotape feedback, which is an excellent technique, highly effective for example, for maternal mental illness, but the training must be intensive in order for it to be effective. Now, when we are evaluating these interventions, we must measure the effectiveness, measure the cost, assess the reliability, and also look at the picture of available resources. That is particularly important, as you can imagine, in developing countries. Reflective practice is a technique for supporting the nurse or health worker in their work with families and young children. It consists of small groups in which the caregiver, the nurse or other health worker, can find support. For example, in remaining culturally aware and sensitive to their families. Support in talking about their own feelings and thoughts that are stirred up by working with infants and their families. Also, finding support in being emotionally open and curious instead of being, for example, critical or judgmental. And these groups offer the health workers or nurses a chance to regularly examine their thoughts and feelings and their own strengths and vulnerabilities. In closing, we want to remind you of the magic moments you can introduce into even brief encounters with new parents and their babies. These encounters can produce lasting positive effects if they are supportive of the parents as parents, and if they occur at this sensitive time in life. These moments are important enough that I want to review them with you. Magic moments happen when the parents feel supported by the nurse, and they begin when the nurse makes a connection with the parents, introducing herself and expressing caring and concern. For example, she inquires about the mother's health and comfort, asks about her experience of pregnancy and the delivery and how she's feeling right now. Then the nurse makes a connection with the parents through the baby, using some of what she learned in the ENBO. She observes the baby and comments on the baby's state, whether she's a great sleeper or alert, and she might note if there's a resemblance between the baby and the parent. She will note if there's an awareness of the parent's presence in the baby, whether the baby turns to the parent's voice or gives hunger cues. The nurse validates the parent's efforts to respond to the baby, saying, for example, "You seem to know when he is hungry," or to ask, "How do you comfort her? What comforts the baby? Is she comforted by rocking?" The nurse inquires about the baby's father and the support system that the mother can rely on when she goes home. These are small moments of connection with the parents. They are made first by attending to the parent, and then by focusing on the baby and making little links between the baby and the parent, such as, "He recognizes your voice," or "He likes the way you sing to him," or "She's a strong girl, look at the way she lifts her head," or "You knew she was hungry, you know your baby so well." These little links from the baby to the parents can have a lasting and powerful effect. They help the baby bond with the parents. These small interventions are supporting the parent-infant relationship. Thank you for your attention. Remember that if you're interested in the infant mental health mini course that includes, in addition to this lecture material, time for questions and discussion, interviews with mothers and fathers of newborn, a great deal of videotape illustration, and the observation of ENBO with parents and newborns, you can access more information at the website supportingchildcaregivers.org.